my topic for today is management of complications of a high-risk pregnancy. First of all, I would like to thank my previous two speakers for giving an insight into what is a high-risk pregnancy and its complications. So, I would just dive into a brief review of what it is again. So, there are some warning signs of a high-risk pregnancy like fever, 38.5 degrees Celsius, and up for more than 24 hours, headache, blurring of vision, generalized swelling of body and puffiness of face, pain in abdomen, palpitations, easy fatigability, and breathlessness at rest. So, if these are the warning signs. It requires immediate visit to the health facility. And so there are some certain high risk conditions that are not to be missed, like pregnancy induced hypertension, preeclampsia, eclampsia, severe anemia, gestational diabetes mellitus, hypothyroidism, intrauterine growth retardation, placenta previa. But so there are a lot of these high risk conditions. I would be focusing for now on four such high risk conditions: pregnancy induced hypertension, severe anemia, gestational diabetes, and syphilis. So, just getting a brief review of what are the hypertensive disorders we have in pregnancy. There is a chronic hypertension that is less than 20 weeks, pregnancy-induced hypertension more than 20 weeks, preeclampsia, and that has to have a component of proteinuria of more than 300. There is severe preeclampsia and eclampsia. So, there are two readings that need to be done, like 4 to 6 hours apart. And if it persistently shows more than 140 to 140 systolic blood pressure and 90 diastolic blood pressure, we will be calling it hypertensive disorder of pregnancy. So, as you know, there are risks of these hypertensive disorders for in the pregnancy, both the mother and the fetus. So, what is our management plan? So, a pregnant mother comes to the ANC. So, we record the rising BP and abnormal weight gain, and we work up the preeclampsia profile. Includes blood workup, serum uric acid, serum creatinine, blood urea, hepatic enzymes, and urine. And so, the definitive treatment for preeclampsia is actually delivery, and one has to wait until lung maturity and satisfactory gestational age have been reached. So, our target is to control the hypertension, assess the severity, monitor the condition, and more importantly, prevent the onset of preeclampsia. There are prediction models for preeclampsia in high-risk pregnancy. I would not go deep into that, but our primary target is just to prevent the control the hypertension. So we have the first line drug as methyl dopa. A proper bed rest might be taken. It's not very strict for preeclampsia and high protein diet. For preventing eclamptic seizures, we can use calcium and we can use prophylactic magnesium sulfate intramuscularly for reducing the risk of preeclampsia. And then we have anemia. So there are certain cardinal signs of anemia like pallor, weakness, breathlessness, and then we work in the CBC, and there are the investigations. So we stratify them into mild, moderate anemias, moderate to severe anemias, and severe anemias. So these three things have different management strategies. We will be using oral iron therapy and folic acid twice daily for mild and moderate anemias. But for moderate to severe anemias, we have to consider parenteral iron therapy, and also for those cases if the patient is non-compliant or intolerant to iron therapy. We might also use anti-emetic drugs like mebendazole or albendazole. And for severe anemias, we have to refer them to the first referral unit. Coming to gestational diabetes mellitus, which has a prevalence of like 10 to 14.3%, there are certain risks of gestational diabetes which underscores why we need to have a comprehensive plan for screening and management of gestational diabetes. So this is a protocol that has been formulated in India, where we test the diabetes GDM at the first antenatal visit using 2 hour 75 oral glucose. And if it is positive, if it crosses the cutoff, then we manage as per GDM guidelines. And if it's negative, we have to repeat the test at 24 to 28 weeks. So this is a two-step approach that even the ACOG recommends. And if the pregnant lady comes at 28 weeks, we have to at least have one test for this. So just in brief, the management ideally should contain dietary interventions and physical exercise to achieve the glycemic targets. And if it fails, then we have to start insulin therapy. So, two things that need to be considered: fetal heart should be monitored by auscultation in each antenatal visit, and the pregnant woman should be explained about the daily fetal activity assessment. Now, syphilis is not very prevalent at this point, but still there are for like screening strategies and management strategies which have been formulated in India that primarily involves injection of benzathine penicillin. Even if there is no laboratory support, we have to use benzathine penicillin.